School of Urology. He will be screening the questions, comments, and also putting it to Dr. Santosh Kumar. And with these words, I invite Professor Santosh Kumar to start the deliberations for today, and his talk, his interactive session, and his face-to-face through this distant learning with the residents. Thank you.
Thank you, Professor Rajiv and Professor Chawla. So, and I'm going to start now.
Yes, welcome.
So, I'm going to discuss pelvic organ prolapse diagnosis and management. First, I will discuss the anatomy, because without understanding of anatomy, discussion on prolapse is futile. And unless you know the anatomy, you will unable to understand the pathology, and you cannot manage it in correct perspective and correct way. So prolapse is, what is prolapse? Prolapse is a sinking sea. If you consider uterus as a ship, so, and all pelvic floor muscle is the base of this ship, and all the fluid in the sea is all fascia. So floor of the sea as a muscle, and the fascia is supporting the sea. And this is a rock. This is the rock which is the pelvic wall, bony pelvic wall. And this rope is tying the ship to the bony wall. So even if floor is weak and this ligament is strong, this ship is not going to sink. If ligament is weak, if floor is weak, this ship is going to sink. So prolapse will happen when your pelvic floor muscle is weak, pelvic fascia is weak, and all ligament is weak. This is the basic pathology which happens in case of prolapse. And it depends whether uterus is prolapse or prolapse of the anterior compartment. If the prolapse of the anterior compartment, then there will be cystocele and urethrocoele or cystourethrocoele. If posterior compartment is involved, there is a prolapse of the anus, prolapse of the rectum, or prolapse of the intestine. Just what I have told, it explained in another way. Pelvic floor, water, and ligament is ropes to the pelvic organ, that is the ship. If this ligament is stretched and pelvic floor is weak, this ship is going to sink, so prolapse is going to develop. And the amount of problem, see, nowadays, most of the, if you consider urological conference is concentrated on the robotics and uro-oncology or stone surgery. But this area is still neglected in our country. If you consider 50% of Paris women will have 10 to 20, will have some prolapse. So half of the population is female, and out of them, half of is a Paris woman, and half of that is having some degree of prolapse. So amount of problem is tremendous, and lifetime risk of surgery is 11%. So if you consider all together, prolapse, and whether it is cystocele, introcele, or urethrocoele or rectocele, 4 crore population will have some or other problem which comes under the prolapse. So you consider, if you are a urologist, you have tremendous opportunity if you practice in this area, because most of the gynecologists is not doing comprehensive practice in this area. Again, urologist is also not concentrating in this area. So I will come in the Dahl and C introduce the 3-level system of support. The uterosacral ligament, the ligament from uterus going to the sacral vertebra, and cardinal ligament, this is also known as McEnroe's ligament and cervical ligament. This is going from the cervix to the lateral pelvic bony wall. So this all ligament is in real sense is not ligament. Ligament connects bone to the bone. But here soft tissue or ligament is connecting visceral organ to the bone. So in true sense, this is not the ligament, but importance is too much to prevent prolapse of pelvic organ. That's why this is given the ligament that can support any vital things. And pelvic fascia and paracarpus which surround all the pelvic viscera and prevent it sinking into the sea. If many tissue comes together, they will give a strength to the various organ. And when you are repairing any pathology, you have to strengthen this fascia, you have to strengthen this ligament, you have to fix all the viscera to this ligament. Whether you do open surgery, whether you do vaginal surgery, whether you do abdominal surgery, or whether you do robotic or laparoscopic surgery. And levator ani muscle is a group of muscle which support lower 1/3 of the vagina. Here in this picture you can see this is transverse cervical ligament. This is also known as McEnroe ligament and cardinal ligament, connecting the uterus to the lateral pelvic wall. This is the uterosacral ligament going posteriorly from the uterus by the side of the rectum to the sacrum. This is another view in which you can see this is sacral vertebra, and this uterosacral ligament is just attaching the part of the uterus and upper part of vagina to the sacrum and prevent it sinking. So knowledge of anatomy is utmost important to understand the pathology which can lead to the prolapse at various level and various organ, and also management. Again, if you see from the below, if patient is lithotomy position and you see from the below, you can see the structure of the perineal body and the various superficial muscle, iliocavernous, ischio-cavernous, perineal membrane, and levator ani, which all supporting all the pelvic organ, whether it is bladder, whether it is urethra, whether it is vagina, whether it is the rectum. In another picture, you can see the bony landmark and the organ and various ligament. This ligament is sacrotuberous ligament, sacrum to ischial tuberosity, and another ligament is connecting, that is Cooper's ligament from the ischial tuberosity to pubic symphysis. So all these ligament is the very important point when you are fixing the paravaginal tissue, uterus to this pelvic wall. Coming to the position of the uterus. Uterus position is anteverted and anteflex. So this position also prevent the prolapse of the uterus, and the ligament is maintaining this. See, this is anteverted, anteflex uterus, and this ligament posteriorly uterosacral ligament is putting the vagina to the lateral pelvic wall, and transverse cervical ligament keeping it antiflex and antiverted, and pivocervical ligament and round ligament, these are the false support. So all these ligament is maintaining antiverted, antiflex position and avoid it from prolapse. Once this ligament, uterosacral ligament is lax, this angle will not maintain, and this angle prevent from uterus coming down, because when there is a pressure from the above, abdominal pressure, the bladder and other pelvic viscera prevent it from going down because it is antiverted, it is right angle. But once this ligament is weak, this uterus and vagina is in a straight line, and any pressure, rise in intra-abdominal pressure pushes the uterus directly into the vagina and prolapse happens. Again, just my emphasis on anatomy, because anatomy is important part of management of this disease. This all is levator ani muscle, and this medial part of levator ani muscle is pivotdactylis muscle. This pivotdactylis muscle, which is going side of the urethra, vagina, and surrounding the rectum, which is the additional support to the all these structure. And there is part of the levator ani muscle, that is pubococcygeus, iliococcygeus, and ischiococcygous. This is fan-shaped muscle which support the all pelvic organ. And in pelvic prolapse, in the prolapse, you have to strengthen all this muscle by doing Kegel exercise. So side by side, I am discussing what is the importance of this muscle, how this muscle prevent the prolapse, and how to strengthen this muscle by doing Kegel exercise. And another nerve supply of all this muscle is pudendal nerve. So when there is multiple pregnancy and obstructed labor, there is a stretching of this nerve and pudendal nerve neuropathy develop. Once pudendal nerve neuropathy develop, the nerve supply to this muscle get affected, and once nerve supply is affected, then this muscle start weakening, and atrophy of this muscle, trophic action of the nerve will lost, and prolapse will happen. So just again emphasis on all these muscle is very vital for prevention of the prolapse, and any type of stretching of abdominal ovarian tumor, ascites, obesity, chronic cough, chronic constipation, repeated labor, obstructed labor can affect this nerve and this muscle, which can lead to prolapse. So now I am going to discuss what are the type of prolapse. So uterovaginal prolapse, apical, when there is apical defect, patient will develop uterovaginal prolapse and introcele, and post hysterectomy vault prolapse. When there is a weakening in anterior part of the vagina, then patient will develop cystocele, and posterior part introcele and rectocele. And when there is a vault prolapse, there is a prolapse and introcele will occur. You can see there is a vault is coming down. After hysterectomy, if you are not supported vaginal vault with the uterosacral ligament or McEnroe ligament, then because at the time of hysterectomy, you are cutting all the ligament. Uterosacral ligament and McEnroe ligament is being divided at the time of hysterectomy to remove the uterus. So vaginal roof, if you are not repairing it and all the ligament is not sutured to the vagina, chances of vault prolapse will be there. And when there is a vault prolapse is there, then introcele will occur. This is another view of anatomy of the all muscle. This is levator ani muscle, and this is the another section. What are the support of the bladder, uterus, rectum? This is the cardinal ligament, transverse cervical ligament, and this is the uterosacral ligament. This is the uterosacral ligament going from uterus to the sacrum. This is the cardinal ligament, transverse cervical ligament going laterally from the uterus. So these both ligament is very much important, which prevent uterus from sinking down and development of the prolapse. So, and after hysterectomy, when you are dividing this ligament, uterosacral ligament and cardinal ligament, you need to repair this ligament back to the vagina, so vaginal wall prolapse will not occur. This is the video which is showing the how the prolapse occurs. When there is uterine prolapse, there is chances of cystocele and rectocele also. In cystocele, bladder prolapse from the vagina, and in enterocele, a small intestine, and rectocele, rectum. So now classification of prolapse. Anterior vaginal wall prolapse is known as anterior compartment prolapse, in which cystocele can occur and erythrocele can occur. In cystocele, patient will have voiding difficulty and bladder is coming through inside the vagina. In erythrocele, patient may have a stress incontinence and sometimes urge incontinence also. In middle compartment prolapse is uterine descent, and posterior compartment prolapse is enterocele and lower part rectocele. So this is another picture showing same thing. And this is the clinical photographs. When you will see uterine prolapse, feature of uterine prolapse is like this. Uterus is coming through the vagina. In procedentia, there will be complete uterus is outside the vagina. And this is picture of post-hysterectomy vaginal wall prolapse. And vaginal wall prolapse can present with enterocele also. So you can see the intestine and thin out the peritoneum. Here again you can see this is the cardinal ligament, this is lateral pelvic wall, this is uterosacral ligament. And in this picture, you can see the elongation of this both ligament and weakening of this both ligament lead to uterine prolapse. And side by side in this picture, you can see how you can repair colposacropexy, in which you can put a mesh from the uterus to the sacrum. And sacrocolpopexy, when uterus is not there, you can attach a mesh with non-absorbable suture to the sacrum, like uterosacral ligament. When uterosacral ligament is divided and weakened, you are supporting the vagina, that is colpos, with the sacrum. So this is sacrocolpopexy with the mesh. This can be done by open surgery, robotic surgery, or laparoscopic surgery. And this is a condition when there is a posterior wall weakness and the vaginal prolapse, in which there is enterocele, rectocele, everything is there. Then sacrocolpopexy and paravaginal repair for total pelvic floor prolapse. These are common cause. Everybody knows that what are the causes of prolapse. So I am leaving this. And this is the complete procedentia, in which you can see the uterus outside the vagina, and you can see the ulcer also, that is known as decubitus ulcer, as it happens in the DVT varicose vein, in which person can develop ulcer in feet. So here the stasis of the, when there is a blood supply comes and venous stasis is there, then patient can develop swelling in the uterus and ulceration. And this procedentia can be associated with, again, voiding dysfunction, and sometimes ureter, both ureter will stretch and comes out into the vagina or get obstructed, and patient can develop bilateral hydrouretronephrosis and renal failure also. And if there is associated rectocele, there will be difficulty in passing a stool, and these are the common symptoms. Again, on cystocele, voiding difficulty and other urinary problem can happen. An examination to rule out any abdominal pathology which is leading to, like ovarian mass, ascites, or any tumor. Vaginal examination to study whether it is cystocele, whether it is urethrocoele, whether there is introcele, or whether there is a rectocele. And there is a method to stage the what is the status of the prolapse, what is the, so from ischial tuberosity, if cervix is there, this is 0. If prolapse is halfway between ischial tuberosity and hymen, this is 1. It is up to the hymen, uterus is up to the hymen, it is 2. And halfway past hymen, it is 3. And complete descent procedentia is 4. So these are the classification of the prolapse. Again, this is the photographic representation of that. There is differential diagnosis. When there is a cystocele, sometimes even Gartner's dermoid cyst or Gartner cyst can confuse with the cystocele. So one can first confirm whether it is Gartner cyst or retention cyst of Wolffian duct or cystocele, because cystocele is reducible, but dermoid cyst of ovary or other cyst is not reducible. And sometimes uterine prolapse can be need to differentiated with elongation of cervix. Here you can see the cervix is elongated, but how can you differentiate whether it is the prolapse or elongated cervix? You can see here is deepening of the fornix. Length of fornix has been increased. If there is elongated cervix, then length of fornix is increased. In case of uterine prolapse, this length is usually reduced. So in clinical examination, these are the pertinent point which you should first see and then decide what are the site of descent, which prolapse is there, with uterine prolapse, introcele is there, cystocele is there, and what is the problem. First you define the problem, then you plan any surgery. And management part, management of these prolapse should be started before the before prolapse happens. Antenatal, internatal, and postnatal care to the gain strength of the all pelvic muscle, and any precipitating factor need to be treated. This is the Kegel exercise. One should do regular Kegel exercise In Kegel exercise, one important thing to know that you contract the only pelvic muscle. There should be no contraction of the abdominal wall muscle. Contraction of the pelvic muscle and relaxation of abdominal muscle is most important when you are teaching Kegel exercise in a patient of prolapse. Other treatment is pessary. This is only in those cases in which you want to delay the surgery till the patient is fit, or if patient is not fit, then you can use the pessary, but pessary is associated with various other complications, and this is not a permanent solution. Pessary can be associated with discharge, irritation, erosion of the and various fistula, and cancer of vagina also. If in between any question if comes, I will happy to give answer.
Dr. Santosh, we'll have question answer after your talk. Whatever questions are there will.
Okay. So these are the factors determining choice of surgery. What is the patient age, whether patient is young, premenopausal, postmenopausal, whether she is completed, his family, what is the degree of prolapse, what is the association with uterine prolapse, any previous surgery which has failed, any associated factor like urinary or fecal incontinence, or any comorbid condition like cardiac disease in which one should like to avoid any laparoscopic and robotic surgery. Various surgical option is there. Repair of anterior defect repair, posterior defect repair, intraocular repair, Fothergill Manchester repair, and Leaford operation. Abdominal operation is mostly sling surgery, and collision and repair of intraocular, sacrocolpopexy, fixing the uterus to the sacrum. If uterus is not there, hysterectomy has been done. Only vagina is there and valve prolapse is there. Colpo suspension. Vagina can be fixed with the mesh to the pelvic wall, that is sacrum. Colposacropexy. And laparoscopic approach can be done like sacral colpopexy or colpoperineopexy, cervicopexy, or hystropexy. Means you fix the cervix with the pelvic wall or fix the uterus with the pelvic wall with the help of mesh. This is repair of the anterior wall defect. Anterior wall defect usually present with cystocele, and cystocele patient will have presentation in difficulty in voiding and something coming out per vagina from anteriorly. And once you reduce it, patient will void normally. So once clinical examination and confirmation of cystocele is there, here main important you give the incision, elevate the vaginal flap, you placate all the tissue so that it will get strength, and you trim out the excess vaginal tissue which has got weakened and close it so cystocele will reduce. Some people use mesh also, putting the mesh, but if there is infection of mesh, then chances of causing problem, and mesh sometimes extruded through the vaginal or sometimes extruded through inside the bladder. We have seen also mesh coming inside the bladder also and coming inside the vagina also. But mostly this surgery is sufficient to reduce cystocele. This is another picture showing cystocele repair. Give incision, placate the supporting tissue, then close the vagina tissue. After trimming, close it above that. And again, paravaginal repair, in which all the vaginal tissue can be placated, and it can after placation, suture can be taken from Cooper's ligament or ischiotuberous ligament to support all the paravaginal tissue and vagina. Here you can see after cystocele repair, if there is paravaginal defect is there, you mobilize the tissue, placate the tissue, and you take suture from the arcus tendinous to the all paravaginal tissue and tightens it. So even paravaginal defect will be repaired. So there is no protrusion from midline or laterally in paravaginal area. And again, posterior colpopepy is same principle as you have done anterior colpopepy. Same principle, elevate the vaginal flap and rectovaginal septum tissue in the rectovaginal septum. You just placate them, and after placation, you trim the vagina and close it. This is the various way of operating. You can do transverse incision after placation. You can close in transverse manner. This is another picture which is showing repair of perineum. This is another picture. Now coming to the Fothergill Manchester operation. This operation is designed to correct uterine descent associated with cystocele or rectocele, in which preservation of uterus is desirable. Female want to preserve uterus and preservation of reproductive function, which is they have not completed the family, want to have children, in which in this case, person has completed the family but want to retain the uterus in this surgery. So in this case, you do preliminary dilatation and curettage to see that there is no uterine pathology. If uterine pathology is there, uterus need to come out. And cervix is elongated, you amputate the cervix and transverse cervical ligament, you placate transverse cervical ligament, which is going to the lateral pelvic wall, that is McEnroe ligament, to the cervix. Repair cystocele by anterior colpopepy, repair posterior wall prolapse, rectocele, introcele by colpoperineodopy. This is in case of female who want to retain the uterus, but family is completed, because in which you are doing amputation of elongated cervix. Amputation of elongated cervix we have done, so this patient will not have pregnancy, because once she will pregnant, abortion will occur. So this is Fothergill Manchester operation only for those female who want to preserve the uterus, want to preserve the mens in those cases, and completed the family. This is the picture which is showing you have amputated the cervix, you have brought the transverse cervical ligament anterior to the uterus or cervix, and you repair the pelvic floor. This is another picture showing same. This is the colpoclysis. Colpoclysis is a less done nowadays. This is only done to obliterate the vagina. Patient cannot undergo big surgery, major surgery. You want to reduce the prolapse and close the vagina. This is done less and less commonly only in those cases in which patient cannot undergo surgery, big surgery. Another option is vaginal hysterectomy with pelvic floor repair can be done. Indication of vaginal hysterectomy with repair of prolapse if this is alternative to Fothergill's operation, Manchester operation, in which patient is completed family, does not want to preserve the uterus for menses, then those cases you can do vaginal hysterectomy and vaginal repair of all prolapse. So principle of all repair is removal of uterus through vaginal route, correction of introcele, approximation of pedicle in midline to give good support, fixation of uterosacral ligament to the vault to prevent prolapse. Bladder support is reconstituted utilizing broad ligament and rod ligament as buttress to repair of cystocele and reconstruction of perineum. This is a vaginal vault prolapse. And now coming to the vaginal vault prolapse. Conservative treatment is pessary, generally not recommended because pessary is only temporary treatment, not a permanent treatment. Transvaginal approach is repair of introcele, Leaford operation, colpoclysis, and sacrospinal colpopexy. Abdominal approach is vault suspension. So vault prolapse can be managed through the vagina or abdomen. But nowadays, most common practice is vault prolapse is doing sacrocolpopexy by laparoscopic and robotic means. Sacrospinal fixation is the process in which right corner of vault is sutured to the medial portion of ischial spine. So vault is coming down, you can feel the ischial spine and fix the vault to the ischial spine. But it is associated with other problem because the nerve is also related to ischial spine, and complication like hemorrhage, sciatic nerve entrapment, and post-op buttock pain is one problem. And there is anterior vaginal wall recurrence is also common. This is the way you can see how vagina is being fixated from the sacrotuberous ligament. Here sacrum is there, ischial tuberosity is there, the sacrotuberous ligament is there, and vagina can be fixed with sacrotuberous ligament. Here vagina and paravaginal tissue can be fixed with various ligament like sacrotuberous ligament or ischiotuberous ligament. I've already discussed sacrocolpopexy, but in sacrocolpopexy, one should need to avoid any injury to presacral or median sacral vessels and nerve plexus. This is another picture is showing mesh repair, that is mesh is attached to the uterus and going to the sacrum. This is sacrocolpopexy. This is another picture which is showing this is sacrum, yellow colored sacrum. This is black is the mesh going both side of the vagina, and even uterus, and can attach to cervix also. This is another picture showing sacrocolpopexy. Sacrocolpopexy can be added with hysterocolpopexy. This is video that's showing cystocele and the urethrocoele. This is rectocele. And this is laparoscopic repair. You are putting mesh from the uterus and vagina to the sacrum. This is sacrocolpopexy. Now, mesh in prolapse surgery, where native tissue repair is superior to biologic graft and synthetic graft. But when native tissue is quite weak, quite atrophic, then it can be used indolently sexually inactive female. Mesh augmentation for recurrent prolapse. When there is a recurrent prolapse is happening, local tissue is weak, one can use mesh. And stage 3-4 prolapse during uterine preservation, but not in childbearing age. Contraindication of using mesh is pregnancy or desire of pregnancy, or pelvic radiation, or pre-existing infection, diabetes, in which chances of infection is quite high. Here, these are the types of mesh one can use: absorbable, non-absorbable. Now coming to the case scenario. 68-year-old female, housewife, completed family, complained of sensation of mass protruding out of vagina for last 8 years. History of menopause 20 years back. No other problem. Obstetrical history, normal vaginal delivery. No history of prolonged labor. No instrument used. She is hypertensive for past 30 years. Diabetic for last 8 years. No family history of similar complaint. On pelvic examination, 6 into 8 centimeter mass protruding per vagina, no ulceration, appears to bulge on sternum, cuff impulsivity, provisional diagnosis and management. Anybody can take this, any resident can take this and manage this case. Hello.
Any taker, any resident who wants to discuss the case with Dr. Santosh? I think Dr. Santosh, you yourself can discuss the case, how you will plan the management of this. And Venki, if you can unmute yourself, and Venki Bhargav. Navneet?
Yes, sir. Yes, sir.
Venki Bhargav, can you unmute and make his
Sir,
ask him to
they
video on?
have the control to unmute, sir.
Yeah, I think I am seeing his answer on the chat. Okay, Dr. Santosh, please carry on.
Okay. So see, this patient is having only one is cystocele and another is uterine prolapse. So cystocele can be repaired by simple incision, how we have explained. And uterine prolapse can be dealt with fixation of this uterus with either sacrotuberous ligament or to the or the tightening of sacro-uterine ligament, that is sacro-uterosacral ligament. We can do by this. Second option is we can do either laparoscopic hysterectomy, and you can put mesh, fix the vagina, fix the interior wall of the vagina with the sacrum. Second case scenario is 58-year-old female, complain of low urinary tract symptoms since 5 years, increased frequency with urgency since 2 years, mixed incontinence since 1 year, urine leak during coughing, and history of staining is present, and constipation since 6 months associated with feeling of incomplete evacuation. Menstrual history, currently menopause for 20 years, post-hysterectomy, 20-year post-hysterectomy done during cesarean section. Previous 2 pregnancy were normal, vaginal delivery with no complication. On examination, BMI is 19, per vaginal examination, atrophic vulva, with mass protruding through the introitus, leading point being vault. No leak on cup impulse, per rectal examination, anal tone normal with hard stool present. Now anybody can take this management. Any resident can want to discuss how will they manage this case?
I think they are not very confident of discussing.
Okay. So again, see, this is the condition of valve prolapse, associated prolapse of introcele and cystocele, valve prolapse with cystocele and introcele. This case again can be managed with sacrocolpopexy. Whole vault is coming down, so there is a cystocele, there is introcele. So we can take a mesh, we can fix it with sacrum, and you can fix it to vagina entirely, and we can fix it to we can create and then recto-vaginal fold or septum. In that area, we can fix the mesh. So introcele, rectocele will also be taken care. So sacrocolpopexy with one loop entirely, one loop going down into recto-vaginal septum will solve all the problem. Third case is on female, 75-year-old female with multiple problem with procedentia, with bilateral hydronephrosis, with raised creatinine. Again, this case scenario in which patient is having procedentia, creatinine is quite high, and patient is quite elderly, 75-year-old. So how can you, this is also very common scenario in our rural area where females is quite neglected, and mostly females will not come out if something is happening this type to her. And many times she comes to the nephrologist, sometimes come to gynecologist, sometimes come to urologist. So here creatinine is raised, female is quite elderly. So in this case, first we have to reduce the uterus back into normal position, and we have to place one pessary. So ulceration of this uterus, congestion of this uterus will go away, and after reduction, if hydronephrosis is not subsiding, then we may have to put a bilateral stent and PUC also. Mostly once there is normal position, uterus in normal position, hydronephrosis usually subsides. But if voiding problem is also associated with prolapse, which is not, and blood is not functioning well, so to tide over the crisis, we first put a bilateral stent to reduce the hydronephrosis, put a catheter. So once creatinine comes down, if general condition improve, then we can plan definitive surgery. Or if we cannot do major surgery, then we can do colpoclysis. We can elevate the flap of vagina, make it raw and close it, so there will be no prolapse. This is easier way to manage terminal quite ill, sick, elderly female. We have already discussed Manchester Fothergill repair, preliminary dilatation and curettage to confirm there is no pathology in uterus, because here you want to preserve the mensage, cervical amputation of the elongated cervix, plication of cardiacal ligament, that is transverse cervical ligament, that ligament coming from the lateral pelvic wall to the cervix. You are strengthening this ligament and you are repairing pelvic floor and repairing any cystocele or introcele. These are the other procedures which is less likely nowadays used. In postmenopausal female, we can do vaginal hysterectomy, anterior colporrhaphy, posterior colporrhaphy, and perineorrhaphy, repair of introcele, and suspend vault with uterosacral or transverse cervical ligament. So here, in most of the cases, ligament and bony landmark is most important, and identifying whether it is a prolapse anterior compartment, whether prolapse posterior compartment, whether prolapse in central compartment. And we can deal with, when you are repairing from vagina, mesh need to be avoided, because more complication comes when you are using mesh inside from the vagina side. But if you are using mesh from the abdominal side, chances of infection is less, chances of extrusion is less. This is all from my side. Thank you.
Dr. Santosh,
Yes, sir.
I'll take few questions from the chat box regarding the one case which was having prolapse. There's one question: if you have a prolapse and SUI together, how you diagnose? And number two, what is the role of urodynamics, and how do you plan the treatment?
See, it has seen that in some cases, if you are repairing prolapse, stress incontinence improves. In some cases, it has seen that after repair of prolapse, stress incontinence exaggerated. So one thing, first we have to discuss with patient whether she needs surgery for both. Then we can repair, we can reduce the prolapse, you can placate the tissue of the anterior wall of the bladder, we can reduce the cystocele, you can placate the tissue around the urethra to correct the urethrocoele, and many times if there is a urethrocoele is there, just repair of that stress urinary incontinence taken care of. Because when there is a prolapse is there, cystocele is there, erythrocele is there, urodynamic parameter may not be correct. So once uterus is normal position and you have done repair of cystocele and erythrocele, many times problem is corrected. If after repair everything does not work, then we can do urodynamics and we can do other tests, video urodynamic, to confirm the stress urinary incontinence and do needful.
There was one case where you have given example of ward prolapse and the patient is presented with mixed incontinence. Probably let us assume the patient had stress incontinence. And in your this case discussion, you have mentioned the treatment of the ward prolapse. So there was a question from, again, Dr. Bhargav, how to manage the SUI in this patient, if that patient is having. How the sacrocolpopexy will relieve the symptoms due to stress incontinence.
See, everything is weakened. So when pelvic floor is going down, urethra is also coming down. When you have restored the anatomy, in stress urinary incontinence, there is a descent of urethra is one of the most important thing. If urethra descent is there, chances of incontinence will be there. If incontinence of high variety and you are expecting it is not going to subside with just repair of whole prolapse, then simultaneously you can do, when you are putting sacrocolpopexy, same time paravaginal tissue can be taken, suture can be taken from paravaginal tissue and it can be attached to the Cooper's ligament. So you are all paravaginal, you are strengthening all paravaginal tissue, paravesical tissue to the Cooper's ligament laterally. You are elevating, you are restoring the anatomy. It is like birch colpo suspension. You are just adding birch colpo suspension with repair of the whole prolapse.
Yeah, so another question from Dr. Shruti was, again, the sacrocolpopexy will take care of ward prolapse. However, do you think the colpopexy will resolve the urinary frequency as well? If the patient is having a, let's say, predominantly frequency and urgency, how much are the urinary symptoms relieved after doing a ward prolapse?
If there is a stress urinary incontinence is there, that part will get relieved. If it is urge incontinence is there, urge incontinence, you have to take care of medical treatment.
Yeah. So let me see, is there any other question on the chat section? Yeah, so that's all from here. But what I would like to just bring to the attention of the residents was the first few slides, if you have noticed, that was actually the best of the lot. I don't know, Dr. Santosh, how you have got the slide. You have taken the pictures, then you have made a notes over there, and then you have taken a scanned picture. What have you done? Actually, I was surprised to see the additions which you have done from your end.
Yeah, I have taken some slides, some image, and we have just mentioned I was practicing, because all anatomy we are usually not reading nowadays anatomy. Yeah. So when anatomy is the basic of the pathology and surgery in this. So I just thought if you know the anatomy, if resident know the anatomy, everything is easy. Knowing the pathology is easy and management is easy. So this is a very nice area in which even urology resident or gynecology, there is lots of scope is there. Nowadays, you must have seen most of the concentration of all the conference is robotic. and uro-oncology. Too much importance has been given. So when I have the incidence of these problem is too much in our country, but it is just we are seeing tip of iceberg. And many people are not venturing because anatomy part, nobody know the anatomy, how, what is the anatomy and how to repair this thing. But once you know the anatomy, repair is very easy.
Absolutely.
So that's why I concentrated the anatomy. And any resident, if want the slide of anatomy, because we have got this slide from different book and different area. So I can send him the slide, anatomical slides.
Dr. Santosh, the additions on the slides, is handwriting was whose? This is very nice handwriting, and probably some notes taken out from the text and added on to the picture.
Yeah. This is not my handwriting. This is some gynecologist handwriting.
Yeah, but this is very nice because what I was seeing is somebody has read the text and made additions on the pictures. So that was very good to watch. And probably all residents should understand that this is one of the very common long question which comes in the exam. The anatomy of the pelvic organ prolapse, the supports of the uterus and the vagina. This is a very common question which is asked. And if you have the diagrams in your mind, it's very easy to explain, and the examiners will be very happy to see if you can reproduce these type of diagrams in the exams. But overall, the lecture was absolutely brilliant. I think what the resident should know that has been covered, and you have gone a little beyond that also. Probably the residents are usually focusing on the cystocele repair, but they should be aware of not only the tissue repair, but a little bit about the mesh repair, the anterior compartment prolapse and the posterior compartment prolapse, and probably few names. And I think everything has been covered, and whatever was left, it has been covered in the 3 index case scenarios. You had a what prolapse? You had a prolapse with bilateral hydrouterine nephrosis, and he was giving an example how these patients can be in the nephrology, and you never know, these patients may be already on dialysis. Only when urology consult is given, then only you will know that dilated ureter with the J shape of palm tree and all that. It's a very common scenario, and probably this has been amply, very nicely conveyed. The message conveyed from Dr. Santosh. If you have no more questions, residents, then I'll ask Dr. Rajiv Sood to give the concluding remarks, and then we can sign off. Dr. Rajiv Sood. Dr. Sood. I think he's got Navneet.
Ji, sir.
Dr. Sood is there online. I just saw him.
Dr. Sood is here, sir, but I have requested him to unmute and start his video.
Dr. Sood. I'm not seeing him. Yeah, he's there only. Yeah, 1 minute. Just Dr. Santosh, just bear with for a few minutes.
Okay, no problem, sir.
Yeah, he may be busy in some
Yeah.
call. Yeah. So this cystocele repair and all that is a gynecologist domain, or in PGI urologist domain?
In PGI urologist domain.
Very good, excellent.
Okay.
And what about the posterior compartment repair and all that? That urologist?
We are doing laparoscopically, usually mesh with using mesh, intra-abdominal approach.
Okay,
because
fine.
urologist is more because doing radical cystectomy, radical prostatectomy, pelvic area is more friendly to them. So we are doing mostly through abdominal route. Cystocele repair is there, then it is from below. Only rectocele is there. Then
I think this resident should make whatever message you are conveying, that the functional urology and female urology is something like a very less travel territory, and the newer residents should look into this area, and not only just get their interest only in uro-oncology or some lab and robotics. Because if you are a good female urologist, you are not only serving the urology patient, but you will be most sought after urologist by the gynecologist. And you can imagine for one urologist, there are 20 or 30 gynecologists in a city. So you will be the most sought after urologist. So this is very open field. Still, not many people having interest in that. Somewhere I am reminded of the quote that urologists fail to look beyond the waistline. So these areas are probably this should invoke some interest from the residents, especially the residents who are joining new, and probably develop into interest into this subspecialty, and probably progress forward by doing fellowships or going into the places where this work is going on in plenty. With this, Dr. Santosh, I'll thank you very much, and I'll hand over to Dr. Rajiv Sood for concluding remarks and official vote of thanks. Over to you, sir.
Thank you. Thank you. Thank you, sir.
Dr. Sood?
Hello.
Yes, sir.
Am I audible?
Yes, sir.
Yes.
Okay. Actually, I'm in a meeting here, so I have in between. I was keeping watch on everything because the health minister was coming here. So I'm thankful to Professor Santosh Kumar for wonderful lecture, and also the questions which have come that has shown that a lot of interest has been generated by him amongst the residents, and also the points which have been discussed. They were uh, doing all the justice to the topic and all the justice to the teaching session which he has taken. So this lecture has also gone to archives, and this is available for time to come. All the residents are advised to tell those who have missed the lecture today. After 2 days, it will be available, and it is going to be very, very useful for this, and also make them wonderful and interactive mind. They can diagnose, treat, and also contribute to the urological practice. I thank Urological Society and Indian School of Urology, and also on behalf of co-chairman Dr. Chavla, and also President Secretary of Urological Society, to everybody, all the participants in the Professor Santosh Kumar.
Thank you very much, Dr. Sood, for your nice comments.
Yeah, thank you, Dr. Santosh. Thank you very much.
Thank you, Dr. Chavla. Thank you.
Thank you.
Yeah, and we meet on Tuesday. The class is on bladder pain syndrome and interstitial cystitis, and this will be by Dr. Rajesh Taneja. So we meet again on Tuesday now. Thank you very much. Thank you, Dr. Deep Sood. Good night. Thank you, Dr. Santosh.
Good night, everybody.
Okay.
Thank you.
Yeah,
Thank
goodbye,
you.
everybody.
Thank you.